personal with all the events there. So again, thank you all for joining our TikTok webinar today. This is session 4 of 10, and we're offering nursing contact hours for each of the 10 sessions. They are also being recorded, and the recordings are available on our Mountain Pacific website. So if you're interested in listening to previous sessions, you are welcome to do so. The next session will be on January 13th at 3 p.m. Mountain Time. There will also be polling questions today that we'll bring up during the webinar, and as well as a link to the evaluation. So if you want to pull up that first question, that first polling question, I do need to know whether you'll be claiming nursing CEs today. So our polling question has that, what your credentials are. So I am able to determine who needs to get an emailed CE certificate after the webinar today. You'll also be able to unmute yourself, but please keep yourself muted while the presenters are speaking. We will have time at the end for question and answers, and also you can use the chat box to enter in questions and comments during the webinar as well. And we also sent out a homework question out ahead of time, which was, do you have a variety of resources to help care for those with dementia, both online and in person? And so if you'd be willing to share during today's webinar. And then, so after I introduce the speakers, they'll recap what was discussed during the last session on December 16th, and then we'll start with this week's topic of dementia. So now I want to introduce our speakers. So Dr. Erica Zuby is child psychiatry, mental health advocacy, and policy. Dr. Azubi co-founded Frontier Psychiatry in 2019 to introduce an accelerated, more aggressive response to Montana's growing mental health crisis. He served as chair of psychiatry at the Billings Clinic for 5 years, during which time he led the creation of Montana's first psychiatry residency program and Montana's first empath unit for emergency psychiatric care. Before moving to Montana in 2013, Dr. Azubi spent 10 years at the Yale School of Medicine, where he earned his MD and completed postgraduate training in general psychiatry and child adolescent psychiatry. And Dr. Reza Gomi, neuropsychiatry and geriatric psychiatry. Dr. Gomi holds a BS in computer engineering from Rensselaer Polytechnic Institute. I always slaughter that name. MSc in biomedical engineering from Johns Hopkins University and an MD from the University of Massachusetts. He completed a residency in psychiatry and a fellowship in movement disorders and behavioral neurology at the University of Washington. He currently practices neuropsychiatry with a focus on cognitive memory and movement disorders. He is also active in engineering and clinic research, focusing on using advanced technologies such as voice recognition to track and monitor treatment of neuropsychiatric diseases such as depression, schizophrenia, Alzheimer's, and Parkinson's disease. So with that, we have some very intelligent speakers. Thank you, and I'll open it up to you guys to share your screen.
Thank you for calling me intelligent.
You bet you are.
Reza, you're muted, buddy.
Thank you. Thank you. We rehearsed the intelligence line today, so thank you for that. It's much appreciated. So here's TikTok number 4. So for those of you who've been with us throughout, this is going to be a new talk focused more on dementia. And for those of you who are new to the series, we'll do a quick recap because our goal is to help everyone be able to come and go. So if some of you have not been to the previous talks, we'll do a quick review of what we've done to date in the previous 3 talks. And I appreciate the lovely introduction. Mount Pacific has been wonderful to work with, and this has been a lot of fun for us. Just in the way of a couple quick disclosures. Eric and I are both owners of Frontier Psychiatry, and I separately have some part-time work with BrainCheck, which relevant to today's talk as we do computerized cognitive testing. To kind of zoom out in the agenda, today's the 4th of a series of 10 talks. And previously we had talked about trauma-informed care in terms of an introduction. We talked about a case example with Lewistown Nursing Home in Montana. And then we also talked last week about the impact of loneliness and isolation in nursing homes. And today we'll go on to speak about dementia. Just in terms of a review, and I'm going to just minimize this guy. So trauma-informed care, again, this is not meant to be intimidating in terms of sharing, these new regulations, but with CMS asking facilities to ensure their residents who are trauma survivors, which really is a very high percentage. You can consider that to be the majority of residents, to be receiving culturally competent trauma-informed care. And that's not meant to be something you have to be worried about having check boxes or, really being under scrutiny. It's really meant to be a guideline, and talks like this and series like this by Mountain Pacific are exactly there to help you along the way. So I just want to make sure, I think it can sound intimidating when you hear, CMS, there's new federal regulations, and that always sounds a little bit scary, but really that's not our experience with these regulations. They're not meant to be, it's just meant to expand perspective and education. And so, we want everyone attending today to be able to feel comfortable assessing for past trauma. And that can take many forms. And some of what we talked about was really just building rapport with patients, getting to know them. And most of the time in our experience, people are somewhat forthcoming about at least referring to, doesn't need to go into, just like with when we're doing therapy with patients directly, they don't need to relive those experiences. They don't need to go into exquisite detail, but even just being aware that there was a trauma can be really helpful. And Eric did a great job in the first talk, kind of expanding our perspective of what our adverse childhood experiences. And that covers a bunch of different areas, right? So there's abuse, neglect, and household dysfunction. All of these can be considered trauma. So it's best for us not to narrow that definition and to be open to multiple sources of trauma. And on that bottom left figure is just pointing out that adverse childhood experiences, trauma in early life, has huge impacts on your health across all domains, and not just health, but education, occupation, and everything. In talk number 2, we went over this real world example where we worked collaboratively, we still work collaboratively. It's been a wonderful relationship for us with the Montana Mental Health Nursing Care Center in Lewistown, Montana. So it's a wonderful resource for the state. And we've been able to work on bringing some trauma-informed care into their day-to-day. And some of that took the shape of increasing patient autonomy and also increasing attention where patients before, even something as simple as increasing the frequency of visits with the psychiatrist in order to better understand how trauma was affecting them and to treat that trauma. So even just starting with what may seem like a small step, we were able to accomplish this. And we shared some data to that end of showing an increase in the number of psychiatrist visits, and decrease in the number of medications used, really trying to focus on using in-person, relying on the staff there who do an amazing job in interventions and paying attention to people's trauma so that the need for medication actually is reduced. And that's really a sign for us as psychiatrists that we're doing a good job, actually, believe it or not. And I know that may not be everyone's experience, but trying to look for ways to reduce medication. In talk number 3, the last talk 2 weeks ago, we spoke about loneliness in nursing homes and trauma-informed care, and really loneliness within and outside of nursing homes. It's not just living in nursing homes, and this is something that affects many people, especially older. We talked about how in the data that shows loneliness significantly increases the risk of premature death in many different types of health effects, such as heart failure and stroke. And that figure on the bottom right there was to demonstrate that these numbers, these hazard ratios, are actually larger in terms of impact on your life expectancy for social connection and loneliness than even smoking has a smaller impact. Obesity, you can see the flu vaccine down there, air pollution, physical activity. It's pretty amazing how powerful social isolation is. And many of us probably have examples from direct family members when we can think of when in older ages, if a loved one passed away and they became lonely, the life expectancy tends to be much shorter. And a highlight for today, which is relevant, is more than expected dementia deaths during COVID. So higher rates of dementia, social isolation was associated with 50% increased risk of dementia. And then in the last 9 months, we've seen a spike in dementia deaths, not directly because of the coronavirus, meaning being sick with the virus, but the secondary impact of loneliness and isolation because everyone's locked down. We shared some tools that you can find online just by searching on the web in terms of looking for, if you're curious to measure loneliness in your facility with some very simple, some of these are very short questionnaires, can be helpful. And then we also touched on some opportunities to relieve isolation during COVID. So what can we do when we have so many limited resources right now, and many things that we used to rely on are not available? But we went over some creative ways to try to help relieve some of the social isolation. Remember, this is a tough period. I mean, there is no perfect solution, but even these small interventions can go a long way, as you saw how strong the impact of social isolation is on your health. Now tying back to a slide as we get ready to talk about dementia that Eric shared in his first talk, is that what a high rate of childhood trauma increases the risk of dementia to such a large degree. So even looking at large cohort studies like in Japan and showing that the more adverse childhood experiences you have, the more risk for dementia. And so this is how we tie trauma-informed care and attention to adverse childhood experiences to dementia. But in order to do that first, I want to talk about what my bread and butter is and how I go about identifying, diagnosing, screening for dementia, and then what we try to do for it. First polling question, if we're able to pull that up, is trying to ask, in terms of what you guys are aware of, what percentage of the people you work with have dementia? Are we able to pull that up? Let me know. That's doable. Oh, there it is. Okay. Those results will pop up in just a second. And as we're waiting for those results to come back, just wanted to throw up a couple warm-up questions. Take a second to look at these. And again, I can't see your faces and whatnot, so please jump in at any point with any questions, or if something's not clear. There will be some opportunities as well to ask some questions, but there we go. So somewhat as expected, but 85+% of people, where probably half or more of their clientele have dementia. So this is pretty much as expected. So before we go to that one, let me come back here. So warm-up questions. Which of the following conditions is a relatively common cause of cognitive dysfunction in older individuals? And we're throwing out Alzheimer's disease, primary medical illness, psychiatric illness, or other factors like suboptimal sleep, pain, medications superimposed on normal aging, Lewy body diseases. Those are things like Lewy body dementia, or Parkinson's disease. And then we have frontotemporal lobar degeneration, or FTD. Frontotemporal dementia is another way it's commonly referred to as. Does anyone want to throw out any ideas? Which one of these are relatively common causes? Someone be brave and unmute yourself and say something.
I'm going to go with B.
Nice. Very common cause. Yep. Dementia, anxiety, sleep apnea, all very common causes of cognitive dysfunction as we get older. Any other, would you consider any of the others?
Would you put traumatic brain injury under B?
I think so. Yeah, I think it's meant to capture TBI. Yeah. And then Alzheimer's, and part of this is to point out Alzheimer's is relatively common. It's very underdiagnosed currently, but it is very common. Lewy body diseases are also very, very common, starting to be more and more recognized. So those Parkinson's class of symptoms or Lewy body dementias. Robin Williams ended up passing away from Lewy body dementia. These were things that he was never diagnosed with it until his autopsy. And so these are all, Lewy bodies are found on more and more after death, unfortunately. And so we're getting better at catching it earlier. Frontotemporal lobar degeneration is actually the one that's not as common. You've heard of FTD because the behavioral variants cause a very kind of famous, disinhibited, impulsive, loud, intrusive. So people know about it, but it's not all that common. Question number 2, true or false? Subjective memory concerns without objective evidence of cognitive impairment on testing are almost always related to anxiety. Someone jump out. Someone besides the usual crowd. Someone give me true or false on that one. Don't make me call on you.
I was going to say, should we play roulette and just pick someone?
All right.
I'm going to say Colleen Sperry.
Yes. Don't be scared.
Don't be shy. Push your unmute button. It should be if you kind of hover over your screen. And then if you are on only by phone, you can press *6 to unmute yourself as well. Nothing from Colleen. How about Jennifer Leuzzi? Either guys can't find your unmute button or you're too shy.
Someone jump in. We want you guys to be interactive, so be ready to jump in.
I'll go for A. I would say false.
Great, thank you so much. Yes, that is false, right? We when people come in with subjective means that, oh, they seem to be functioning fine. Nothing seems to be objectively wrong, measurably wrong, but someone's worried about it. We're realizing more and more that people, especially people that are used to maybe have a high level of education or used to doing lots of complicated things, turns out they might have some insight and might be noticing changes much earlier than our traditional tests have been able to pick up. So we do want to take that seriously. True or false for B, Alzheimer's disease, Lewy body disease, and vascular dementia are mutually exclusive and should not be diagnosed in the same patient. So true or false? Can you have those in the same patient or not? Someone else jump in.
I'll say true.
Okay, good guess. So thank you for participating. So Alzheimer's, Lewy body, and vascular dementia can be, and I rephrase it, so I might have confused, but it can be diagnosed in the same patient. So keep that in mind that we're finding more and more, it's the case that pathologies overlap rather than being separate. So for example, vascular and Alzheimer's tend to go often together. Part C, Alzheimer's disease always causes a loss of memory for recent events. Information is the most prominent early symptom. So that classic amnestic, short-term memory loss. Is that true or false? Is that always the case? True or false?
False.
Very good. So there are variable Alzheimer's diseases, and we'll get into that a little bit, but the most common is that amnestic short-term memory loss, but there are other presenting symptoms. And then part D, dementia and major neurocognitive disorder are synonymous. True or false? Those the same term or different?
False.
So that one is true. So this is part of what we're going to be talking about today, is to help people understand. It's kind of in the diagnosis ICD-10 world, dementia is not a diagnosis code. That's sort of just like an umbrella. It would be like saying you have cancer. You can't diagnose someone with cancer. You got to be very specific. Major neurocognitive disorder is an attempt of making it a little more specific. So there's subjective memory disorder, subjective cognitive disorder, there's mild cognitive disorder, and there's major neurocognitive disorder. We'll get into what those mean. it's an attempt at being a little more specific. Thank you guys, really appreciate it. One more polling question. What percentage of those with dementia have a specific dementia diagnosis? So of those people that you work with and you think about, how many do you know is just saying, oh, they have dementia in their chart or in their records, or do they have a specific diagnosis like an Alzheimer's or Lewy body dementia, or frontotemporal dementia? So what percentage have a specific diagnosis? Thank you for responding to that. So in terms of dementia as an overview, and I'm sure the results will pop up. Yeah, there we go. What percentage of those? So great. This is about what my experience has been too, but you can see that the majority do not have a specific diagnosis. And that's just something nationally, internationally, we're really working hard to change. And I'll touch on why that is. And that's really the bulk of today's talk. So dementia is this umbrella term and I spent a lot of time, oh, sorry. My thing does not like to cooperate. I spent a lot of time with education for providers. This, all the way to neurologists. This is not really still a standard part of medical education. So even when I'm seeing, and I had to do all this extra fellowship and training to really understand this. So in general psychiatry, general neurology residency, you really don't get much in the way of dementia training. So no one's exempt from this. I mean, I spent a lot of my time with educating people about this, but starting with dementia being an umbrella term, there's a whole bunch of neurodegenerative diseases that fall under dementia. You can have dementia from all kinds of stuff. You can also have dementia from things like strokes and vascular diseases that are not traditionally thought of as dementia. It's whatever is neurodegenerative, whatever is getting worse over time and causing something that's chronic, persistent, and impairing your functioning. So it's not normal. That's something you will often have to help your residents with is, oh, my grandparents all had dementia. And, that's what happens when you get older. That's not the case. And helping them understand that it's not normal aging. And some of the symptoms of dementia are potentially caused by treatable conditions. And I'll show you a figure later of what we think those percentages are. Some of the key points that I just want to kind of drill in for today. Most forms of dementia come on slowly, may be preceded by mild cognitive impairment. But remember, mild cognitive impairment is this cluster that does not include functional loss. So people should be fully independent. They may be able to do, you might be able to see MCI on a MOCA or an MMSE or some kind of neuropsychological testing. You could measure it, but they should be functionally independent. They shouldn't be getting lost. They shouldn't be leaving the stove on. They shouldn't be missing their bill payments, things like that. Alzheimer's is the most common, but not the only type of dementia. And that's something we're just going to really drill into. The diagnosis of dementia requires, oh, go ahead.
Sorry, I'm so sorry. So I just to, I guess, clarify. So you're saying once you've crossed, and I think I remember you when you were sort of teaching me about this, once you've crossed, somebody has, let's say, a low score, relatively low score in the range where MOCA would say, okay, it's mild cognitive impairment. That's still mild, but once you cross over into functional impairment, that's when things change?
Correct. So once you start having, oh, I'm getting lost or I'm missing some bill payments, I can't remember my appointments, that's when you're crossing into dementia. And specifically 2 or more areas of cognitive function, then you call it dementia or major neurocognitive impairment. I think this thing has a timer on, that's why it keeps doing that. So dementia of Alzheimer's has been described as progressing through 3 stages. And then so once you do cross over, let's say you're pretty independent, you might live on your own still, but you're kind of forgetting your conversations, you're repeating yourself, but you're surviving. That's early Alzheimer's. Middle or moderate stage, that's when you really do need, it's pretty important that you have caregiver support. You really shouldn't be living on your own bike, shouldn't be driving at that point, but you're still exercising, you can kind of get up, there's still lots of things you can do. And late stage is when you've lost a significant portion of your independence. You absolutely need supervision. You probably need supervision most of the time, just in terms of wandering off or just kind of getting up and eating, being reminded to eat. So there are these stages. Diagnosis is predominantly made in the real world, right, by primary care, geriatrics, neuropsychologists, and neurologists. And not all memory issues are indicative of Alzheimer's or another type of dementia. So one thing that happens is you get younger people that have memory issues that are like, oh, brushed off, like, oh, it's probably not dementia. It's like, you're in something else, anxiety, something. And then you get older people, if you're like 90 and you say a memory issue, it's very easy to say, oh my God, this is probably dementia. And so you got to be careful because it goes both ways. It's not necessarily the case. One thing I really like to point out to people, normal aging. So this is a great graph to pay attention to. And keep in mind on the left-hand side there, those T-scores, which means kind of like, think about 50 as the average compared against your age group. This is not representing a huge change. So as you get older, you can see from age 25 all the way to 81, things like numeric ability should not really change. That should stay right along there. There's a little bit of fluctuation. Verbal ability, you can see actually keeps increasing into your 50s and even into your 60s. So like for Eric, you still have some hope, Eric. You shouldn't feel too down about it. And then things like this. But then look at this, spatial orientation, perceptual speed. These are the things we're used to hearing from our parents and our grandparents and so on, right? Like having trouble driving at night, having trouble like backing out of the driveway, being quick, in terms of processing. That stuff you may notice that, and that is part of normal aging. It shouldn't be severe. So meaning you shouldn't then not be able to pay your bill at the restaurant, but it just might take a little longer. You should still be functional, but keep this in mind. There is some changes with normal aging. So dysexecutive syndrome, so comorbid factors influencing cognition. When we say dysexecutive, we mean frontal lobe, executive function, that executive in your brain making those decisions. What gets in the way? If your frontal lobe, if your executive in your brain is not working, you will look like you have dementia because you're going to be confused, not able to track information, your speed's going to be slow. And sorry about that. I don't know why there's a timer. So general medical illness, cardiac, renal, hepatic, so all those things can cause executive dysfunction, psychiatric illness, anxiety, depression, PTSD, bipolar disorder, that all causes it.
Hey, Reza, I'm so sorry to interrupt you again while you're doing that. Two quick things. One is there was one question in chat said, I'm so confused about the difference between Alzheimer's and dementia. So I threw in an answer that I think is great.
And who asked that? Because I want to make sure we clarify that.
Go ahead. Enol1, who is that?
Okay, so let me make sure we answer that, and I want to make sure it's clear. Dementia, we're saying, is a sort of umbrella term, like kind of an old used term. If you look back historically, 80 years ago, 50 years, people would say, oh, they were just demented, because it was all about, they just weren't functioning. They were older, generally, they were clearly having memory issues. And over time now, that's become this kind of like grab bag term. So think of cancer, and about 50 years ago, let's say you would have gone to the doctor and they'd say, oh, you have cancer. And we weren't as good about saying what kind of cancer. So a lot of people were just walking around saying, oh, I have cancer. But was it breast cancer? Was it lung cancer? Was it what we weren't as good at saying. We just knew, oh, wow, you have some huge tumor. We don't know what it is. Same with dementia. It was, oh, you're acting funny, you can't remember stuff, and you're not functioning well. And so as we've gone better scientifically, it's moved into and we've shed more light on it. We've gotten more specific. And Alzheimer's is an example of, here's a specific pathology. If we say Alzheimer's, we mean there's specific proteins doing specific damage in your brain. And that's causing the dementia. That's causing the inability to think. Does that clarify it?
So nobody has a diagnosis of dementia?
So good question. That's a functional diagnosis, meaning that's just telling me how you're doing, but that's not telling me why. So you can have dementia, but it's more important to know, why do you have dementia? So, oh, I have Alzheimer's, or I have sleep apnea. I just look like I have dementia. Or so that does capture how you're doing, but doesn't tell me why and then how to fix it. Does that make sense?
That's actually a great discussion. So another question related to that, Reza, is so are some forms of dementia reversible and some are not?
Correct, exactly. So for example, what if you have dementia due to very low thyroid or B12 deficiency? Well, you're gonna look like someone that has Alzheimer's, but it's not Alzheimer's. It's B12 or thyroid or many other things, and you can reverse that. You can retake that, and you'll actually get better.
That's great.
Does
Thanks.
that make sense? It's critical that you guys understand, and this is this is the number one thing I really enjoy doing and spending my time, but it's educating around this piece. This part is critical, and we're at a huge turning point, which I'll touch on later in terms of new drugs that are going to come out and reasons that we need a specific diagnosis. So please, put it in the chat if you're not able to verbally say anything, but let me know if I need to come back to that. And so on this slide, to that point, B12, and you can see vitamin D and thiamine down there, chronic pain. Again, if you're constantly in pain, if you have like slip disc in your back or just chronic pain syndrome, your frontal lobe just can't function. You're not gonna be able to listen. Like if someone's like, hey, remember the shopping list, but you're 9 out of 10 pain. Are you gonna remember that shopping list? Of course not. So keep in mind, these are all ways, and then if you're on opiates or hypnotics or benzos, also, those are shutting down that frontal lobe. Sleep apnea and so on, you get the idea. And then all the psychiatric illnesses. So childhood traumas are going to contribute to how you experience and manifest memory loss. Now, what we know now is over the years, and this is over decades, that yellow-orange line, that gradual accumulation of neuropathology. So for example, in Alzheimer's, there's amyloid and tau proteins slowly building up over decades, we're finding out. So by the time you're diagnosed, they've probably been building up for 10, 20, maybe more years. Now, early on, when it's just a little bit in your brain is very resilient. It can take a beating, just like you've seen, right? Football players who get smashed in the head over and over again. It takes a lot of beating to them finally have an issue. So your body is very resilient. So you won't have symptoms until there's some certain amount that it crosses over. Then you get that mild cognitive impairment. You have, you can't do well in the MOCA. You don't do well in your testing, but boy, do you have some measurable issues, but you're able to function. And then dementia, you kind of cross over this point where you have a ton of proteins building up in your brain and it turns into dementia. So disease prior to onset of symptoms. One thing I wanted to point out, and this is just getting a little bit technical, but I just kind of want to give you guys a flavor of what I'm doing in clinic with patients is if you look down in the bottom left there in your age, you have amyloid plaques at autopsy. So amyloid protein, that's an Alzheimer's protein, and then the prevalence of dementia. So the point of amyloid being in your brain comes before the dementia is actually noticed and you can't function in your life. And you can see there's a gap of years there. So people that were autopsied, they had amyloid in their brain, but it wasn't until years later that they had diagnosable dementia. So your brain can really take that beating up, that accumulation before it shows that protein. Here, now what gets interesting is not just in your brain, but in a specific part of your brain, your precuneus. Look at this, how well this predicts Alzheimer's. But amyloid loves to go in specific places. So not just everywhere in your brain, it goes in your precuneus. And look at that line. It really favors the precuneus. And on your right there, that MRI, this is a picture of a precuneus. And what that means is it's, if you think of the crown of your head, it's where the brain folds together. The precuneus is that medial parietal lobe. So it's that middle part of your crown. And so this is near the center of your brain on both sides. And this is actually a real patient I saw recently in one of the nursing homes in Montana. And she has gone 10 years plus without a diagnosis, but just being called dementia. But a lot of that had to do with social issues and no one's fault. But I went and said, you know what, I want to know what's going on. And this was a very classic case of Alzheimer's. And look at the rest of her brain. The rest of her brain actually looks relatively okay. But look, right at her precuneus, look how much damage that amyloid and tau has caused. This can be over 90, 95% specific, this sign for Alzheimer's. Do you guys appreciate that? Do you see those wrinkles here are much wider than the wrinkles everywhere else in her brain? Do you see that? Someone give me some feedback. Am I crazy or do you see it?
We see it.
Yes to
All right,
both.
All right, because people think I'm crazy too, so you gotta be careful. So, anyways, this was a great example of where I can say now I can give this person a diagnosis of Alzheimer's disease, and I'll explain why that's helpful. So, when we're talking about Alzheimer's, we're talking about specific proteins going to specific parts of the brain, and that's how we get better diagnosing without having to actually take a biopsy of the brain. Now, check this out. This is pretty fascinating. Early detection and intervention. These different colored lines represent different markers, biological markers in the brain. Now, remember, all the way to the right, that purple line, that's clinical function. So traditionally, we're talking about, your 70s, 80s, 90s, you're getting lost, you're leaving the stove on, and that's traditionally where we say, oh, you have dementia. Now, in terms of function, check it out. A little bit earlier, you get cognitive decline. So I can do a MOCA, and in a few years, maybe when you were 70 instead of 75, I could detect that you were starting to not remember the 10 words in 10 minutes rather than only 5 words. Now look, MRI brain structure, years before, like that precuneus image I just showed you, that can start showing up a few years before. Now, even earlier, check it out, CSF tau or p-tau. So this is in your spinal fluid, the tau protein. Amyloid and tau are both very big players when it comes to Alzheimer's. So tau and p-tau. You got that hippocampal volume, which is a memory part of your memory centers, and I'll show you a picture of that. PET scans, if some of you are familiar with PET scans, it's a functional imaging. That's when we give a radioactive sugar to see what parts of your brain are working. That can show up years, 10, 20 years before a traditional diagnosis. So all of a sudden, we're getting, and then look at this, CSF amyloid. So measuring the amyloid beta 42 in your CSF might be all the way back here in the pre-symptomatic stage. So all of a sudden, in your 50s, we might be able to say you have Alzheimer's, even though you're way before dementia. You might be 20 years before. So this is amazing in the sense that we're getting way better at identifying illness earlier. The big question that comes up is why bother? What's the importance of the diagnosis? Well, in what I do, this is what I feel very strongly about. I need to know the diagnosis is correct. I want people to have that clarity. People, the vast majority of the time, people say, how can you do this? Like, it's such a depressing thing to do, but humans like to know what's going on with them. This is across the board. So it's actually tends to be a rewarding and very positive experience when you can walk someone through what's really understanding, what's going on in their brain. What symptoms are part of the disease, and then all of a sudden you have insight, what's part of the disease and what's not. It's extremely important to know, oh, I should be treating this depression and anxiety. That's not part of the Alzheimer's, or maybe it is. Planning for the future appropriately, the genetic implications for certain dementias, certain diseases, right? We have to think about your kids and your grandkids. Bringing in the right team, multidisciplinary team. I work with pharmacists and social workers and case managers and so on. It's critical. It is impossible to take care of someone with dementia without that whole team. I'll go as far as saying that. Providing support and education, receiving treatment as soon as it becomes available. So, and then research implications, how can we develop new therapeutics if we don't know what diagnosis they have? Keep in mind, if a new study comes out and we're saying, oh, we have a new drug we want to test, but we need to enroll people with Alzheimer's. Well, if everyone's just diagnosed with dementia, how are we going to know who has Alzheimer's and who's going to be eligible for that treatment? The new treatments that are going to be coming out and approved by the FDA are going to require some kind of confirmation of a specific diagnosis, like an Alzheimer's. So people that just have a dementia in their chart, they're going to have to get more testing to figure out if they're a candidate or not. And we're on the verge of having some new medications on the market. We'll come back to that again.
I had put a question into chat, and it was probably about 3-4 years ago. I had read an article. I don't think it was an actual study, but it said something about Alzheimer's being considered, quote, diabetes of the brain.
Yes. So part of that is looking at, it's trying to shift our focus into being and this is getting at like, how do we look at and treat Alzheimer's? That's trying to get at the point of, you look at it as a chronic diagnosis, not as a death sentence, not as a, oh, my life is over. It's more of a, before, right? I mean, years ago when you heard about diabetes, it was terrifying. And people now, you realize, it's not as terrifying. You can do something about it. You can improve it even. In diabetes case, there are cases where you can cure it. Unfortunately, with Alzheimer's, we don't have that. But you can certainly improve and still get a lot of quality of life out of that. So that's what that's getting at, is adjusting our framework so that stigma is adjusted. Does that make sense?
I have a question. All of these tests is wonderful if we learn early, but does insurance or Medicare cover?
Good question. So they do when done appropriately. So we can't just, yeah, if I just, you're 55 and you come in, I think I'm losing my memory and I just order a spinal tap or a PET scan, they'll deny that. But if you go through the proper steps, they always do. I do PET scan because I'm a specialist. I do PET scans multiple times a month. And that's after someone's had a brain MRI, their story, the rest of it fits. And I'm starting to get suspicious. And I would say about, let's say half the people I can diagnose with an MRI, then I have to get a PET scan for some that are not clear. Then I have to also go get spinal tap. So it's fewer and fewer, but when you follow the criteria, they absolutely do pay for it. Very good question, because that is a huge concern, because they are expensive. And so you don't want to have someone pay for that out of pocket. I wanted to point out in terms of the confusion around diagnosing. Remember, dementia, which is major neurocognitive disorder, is a severity-based diagnosis, just like mild cognitive impairment, mild neurocognitive disorder. I have measurable changes, but not functional changes. Dementia, I have functional changes and measurable changes, okay? Make sure that's clear. Now, what you're probably used to hearing is Alzheimer's disease, Parkinson's, posterior cortical, some of these are rare, so you might not, dementia with Lewy bodies, behavioral variant frontotemporal dementia. These are syndrome-based. What do I mean by that? It's how people look in clinic. They're shuffling their gait. They don't have arm swing. They, have a tremor. That's a syndrome, meaning I haven't looked inside their brain to know that they have Parkinson's, but it's accurate enough that they probably do. Same with those other things I showed you, just like that precuneus atrophy at the crown of the head. It's probable Alzheimer's, but did I look under a microscope? Can I tell you with 100% certainty? No, but I can get close. And then neuropathology based, that's when you can actually say Alzheimer's. So keep that in mind. This is getting extra critical, but you don't have to worry about this day-to-day, but I just want you to be aware that if I say Lewy body, if I say Alzheimer's, that means technically I've looked under the microscope or I have some marker, meaning I've done that spinal tap. So I've identified, oh, I see that protein in your spinal fluid. That's how I know. So keep that in mind. We're used to seeing severity, we're less used to seeing syndrome, and then we're really less used to seeing neuropathology based, but we're trying to get closer to that so we know how to treat it. So one of the things I'm a huge proponent of is there's this value to providing accurate 4-tier diagnostic formulation. So we want to talk about clinical syndrome, because that's important, global severity, suspected pathology, and then the additional factors like depression, anxiety, sleep apnea, things like that. So the syndrome, what's the syndrome? Oh, they have short-term memory loss. They're forgetting their appointments. They're getting lost. Okay, so that's like this amnestic syndrome. That's what's happening in their real life. Is it mild? Is it subjective? Is it mild? Is it dementia? It's like, oh, that's pretty bad. They need help. They get lost. They're getting in a car accident. So it's dementia. It's major neurocognitive disorder. And then I have to figure out, okay, now why? Why is it? Well, I think it's Alzheimer's because on their brain scan, they had those signs that look like amyloid and tau are hurting them. And then on top of it, oh, and they're taking a bunch of Benadryl every day. They're not sleeping well, et cetera. They're taking benzos. So all of a sudden now, I have a much more helpful formulation of the patient. So instead of saying dementia, putting this all together becomes very, very helpful. And you can start to see how that helps you approach somebody.
Hey, Reza, sorry, there was a question.
Oh, please, thank you. Thanks for calling these out because I can't see them on my screen.
Could you just rephrase it? You mentioned that you wrote. Can you just explain why they're dementia under severity and then Alzheimer's under syndrome? What
yes.
You just said.
Very good question. Yeah. So probable Alzheimer's disease is a syndrome because we're used to thinking about people with Alzheimer's with a certain constellation of symptoms like memory loss, they're getting lost when they're driving, leaving the stove on, leaving the water running, not paying their bills. When we hear that story, we think of the syndrome of Alzheimer's disease. And then severity means how bad is it? So if it's, they're just like forgetting their bills a little bit, but they're living independently, we still think it might be Alzheimer's, but it's mild. Whereas if it's a bunch of those things, they need a caregiver, then it's dementia. And so that's the difference between syndrome and severity. Then as I see them in clinic and I put the whole picture together, I get the brain MRI, do any other testing, blood tests, PET scan, then I can say, I'm pretty sure it's Alzheimer's pathology that's causing this severity and the syndrome of symptoms I'm seeing. Does that make sense?
Resident, maybe another way to say it. I'm just thinking, and I'm
Mhm.
kind of learning with all of you guys because
Please.
this isn't my focus. Is so it sounds like at first, at the top, severity, you're saying we got a problem.
Yeah.
Syndrome based says what kind of problem it is, and then
Yeah.
neuropathology is like what's causing that problem.
Yes. Thank you, Eric. Yeah,
Sure.
that's perfect. And so, and that was leading into this slide where we're talking about we have a problem? You know, how bad is the problem? What kind of problem is it, right? And then what's causing that problem? What's under the microscope? In terms of neurodegenerative, remember we talked about on that test slide about what's less common. You can see on the right there, frontotemporal dementia, sorry, is the least common dementia with Lewy bodies, because these are actually talking about then looking at the brain. Vascular dementia, if you have a bunch of strokes and vascular disease, you're a smoker, you know, a lot of cholesterol, lack of exercise. And then Alzheimer's, you can see, is thought to be the most common. And I'll share these slides with you after. We don't have to go through this in detail, but you'll see these are the kind of symptoms that come up with each of these diagnoses to help us move into a certain. So in terms of syndrome, when I hear memory loss, aphasia, speech issues, loss of words, apraxia, loss of like remembering how to do things, like, oh, I don't remember how to do this. I used to be really good at like putting these puzzles together and now I'm having trouble. Apathy, depression, poor insight. That's the syndrome I'm thinking of Alzheimer's disease. When I start to see these cortical changes on the brain, the parietal temporal lobe, and then I have any confirmation of the protein, that's when I'm saying, okay, pathology is Alzheimer's. So just like Eric's point, there is a problem, what kind of problem, and then what's it happening? So again, a bit about what I do. I'm doing this whole history. So when I see a patient, I'm hearing from family. I need to know from third parties, from caregivers, from other reporters. I need to think about what could be contributing to this, because often I'm making interventions to address the reversible causes and then see, is there still an issue that leads me towards thinking about a neurodegeneration like an Alzheimer's. So you got to treat the psychiatric issues. You got to treat that thyroid, the diabetes, the brain tumor, whatever it might be. And then I'm going to do neuropsychological testing. I'm going to do these brain scans and lumbar punctures. And then that's when I'm putting the whole picture together. And sometimes, remember, it takes time. Sometimes it's not clear up front. So we might have to retest things in a year or two. And sometimes it takes time to really play out. Now, back to drill down on mild cognitive impairment. So you're going to have measurable changes. So if you guys are familiar with the MOCA or MMSC, you know, usually they're on a 30-point scale. Well, pretty much everybody should have 30, right? You get a little bit of leeway if you never finished high school or you have a lower education. But if you're at like 26, 27, you know, you're starting to think like, 24, 25, okay, what's going on? There's some mild cognitive impairment there, but they're independent. They're living okay. They're not messing up things too much. So you can have amnestic because they're forgetting. You can have like dysexecutive, meaning they remember all the words really well, but boy, they can't do a trails B. They can't connect the dots, or they can't draw the cube. They can't draw a clock, but their memory's okay. And then there's multiple domain, meaning a bunch of things are bothered by it. And you can see over here, the hippocampus, this is a memory center, which I'll show you on the MRI. This is at the medial temporal lobe. It's right behind your ears. This is a main memory center for short-term memory. And you can see normal people, this is how big their hippocampus is. And you can just visually see mild cognitive impairment, it's already shrinking, but you're able to function. And then Alzheimer's takes another step down. So these are reliable visual indicators on the brain MRI of what's happening. Now, remember, coming back to dementia, you have to have a interference with functioning. You have to be declining over time. It's not explained by other medical issues, delirium. You don't have like a UTI and you're not untreated illness. You don't have COVID. You know, if you have COVID, you can't diagnose dementia right now because COVID, we know, can cause memory issues. You gotta recover from it. And you gotta have these 2 or more impairments of ability. So remembering new info, you're forgetting your appointments, you're forgetting people's conversations, what you just said, reasoning and judgment, driving around, visual spatial, getting lost, navigating just in the store, the parking lots, language, losing words, very, very common, where you lose the ability to speak in the same fluency you used to, or behavior change, you know, like those, you can have apathy, you can lose interest in things, it might not be depression. So just coming back to some of the imaging I wanted to make sure we're clear on. the hippocampus I was talking about, this is where it is. So this is looking at you straight on. This is like you're wearing a crown over your head. This is at the point of your ears, basically. So you're kind of halfway back and right central. Here's the end of your spinal cord comes up here. This is the midbrain. And then to the left and right of it are your hippocampus. This is a normal one. You see a little bit of space around it, but it's generally pretty full. So this would be normal for 60, 70, even 80. Now look at someone with Alzheimer's. Look at all that space. That hippocampus is shrunken way down. That amyloid and tau has gone in there and killed those brain cells. So they shrink way down. So that's all gone. That precuneus, same thing here. Sorry. That medial temporal lobe, which I showed you in that other slide. See how much shrunken that is compared to the rest of the brain? That's where it likes to go. That PET scan I told you about, it's blurry because it's actually just putting a sugar in your blood. It's looking at where the sugar is going and seeing where in your brain is working. And you can see here, Alzheimer's, I hope you can appreciate this. It's not easy to see on the, multiple screens because it's, it's like the mirror game here. But it's a picture of a picture of a picture. But you see this dark patch here. This is axial image. So you're kind of lying down, the patient's looking up in the tube. And you see how this is a dark patch and then this is a dark patch? That's that precuneus parietal lobe that's not working. So their MRI might have looked normal. So this would have been someone who I thought, I'm pretty sure they have Alzheimer's, but I'm not seeing they're shrinking on the MRI. But years ahead of that, they might have a breakdown. Remember now to think about this, and here's that precuneus. Now keep in mind that when somebody has earlier breakdown, it's happening years in advance. The way to think about it is, if today I cut my nerve in my arm, if I went in right now and cut the nerve in my arm, if you looked at me tomorrow, my arm would look exactly the same, right? Now, in a year from now, once that nerve has been dead and my arm hasn't been used, you'd see the shrinking, right? The muscle's gone and all that. So think of that as an MRI. The MRI, if I cut the brain today, you're not going to see that tomorrow because it takes years and years for it to shrink. It's very slow. Now, the PET scan, that's putting a sugar. If I put the sugar in that nerve in my arm, the nerve can't eat it because it's dead, even though it doesn't look it. And that tells me that it's dark, and that tells me that it's dead. So that will tell me years ahead of time. Does that make sense, guys? And please, and interrupt with questions.
Hey, Reza, I apologize. No, I just want to give you a heads up. It's 3:54.
Oh yeah, I know we're getting
I didn't
close.
I'm sorry. I mean,
thing.
Yep. Sorry.
No. I appreciate it. I got my eye on the time. I'll jump through this. The other thing is that lumbar puncture, which we can do, which tells us if there's that Alzheimer's protein is in your spine. One thing you guys will see in the nursing homes and where you work is people may be on these Alzheimer's medications, and they do help. Donepezil, galantamine, rivastigmine, and then memantine. These are the currently approved medications for different types of dementias, especially Alzheimer's. They do slow down progress. So a lot of people kind of poo-poo on the donepezil and those ones or Aricept because they don't see an immediate improvement. It's not meant to do that. It's meant, and we know this because we followed people for years, that it slows down decline. So for example, someone who's taking donepezil, earlier the better, they will stay independent at home 2 or more years longer than the person that's not taking it. That's why we know it helps. But it's not going to say, it's not like a stimulant like, oh, I'm feeling better today. It's over time that it helps. Just a quick slide to point out, and I always go over when it's the dementia one, because of course it's my interest and I like talking about it nonstop. So neuropsychiatric treatments, point is extremely common. If you have someone with dementia, expect that you're going to see apathy, depression, anxiety, hostility, aggression, those things. That's the rule. It's not the exception. What I wanted to spend more of my time on today, and I will send out the slides so you guys can see this, but what I really like is the non-pharmaceutical approaches. Environmental modifications, social interaction, exercise has huge benefit. I can avoid using medication almost all the time when this is possible. And keep in mind, during COVID, hell of a hard time doing some of this, but we're going to be using it very soon again as we're getting the vaccine. Music therapy, cognitive stimulation therapy, reminiscence. I don't have time to go into specific details, but they've all been studied, all been found to be helpful. Bright light therapy, daylight exposure, group engagement with dementia, Montessori programming they've even done stories with dementia, all have good evidence that you can actually prolong or improve functioning because you can use parts of your brain that are not as damaged. If you see some of the reason I'm throwing out a couple, I know a lot of you are not prescribers, but it's actually important because you have to remember this is not something that the average primary care provider, my wife's a primary care provider, average just doesn't have this kind of training because this is a very subspecialized field. I mean, there's only so much we can do, right, in general medicine. So when you see me, I may use citalopram. It's actually the one that always stands out in studies as being the antidepressant that helps with dementia-related, not just apathy, but also behavior and agitation. So keep that in mind for your patients. The other antidepressants tend not to be helpful once you have dementia. So a lot of people are still on Zoloft or Prozac or others. For whatever reason, those tend to not be helpful in studies. Antipsychotics, if absolutely necessary, a minority of the time, risperidone is the one that stands out to be helpful. Interestingly enough, olanzapine, quetiapine, Haldol never have been found to be helpful. In study after study, they are no better than placebo. In fact, sometimes they're worse. But those are ones we're used to seeing in mental health for other treatments. So we're very used to thinking of those. But I just want to encourage you guys as a team, when you're working with prescribers, remind them, those are actually not very helpful. Risperidone, if the person has Parkinson's or are you worried about that, then we have to think about some other things. Vascular dementia, I just want to throw it out there because it's so common. This is what vascular dementia looks on brain imaging. Just basically think about all this white stuff. We call it white matter disease. You might see in the radiology reports. It's just gunking up your brain because of vascular disease over years. So you're going to have dementia because your brain can't think. It can't communicate. You might not have Alzheimer's. You might not have Parkinson's, but those parts of your brain, since they can't communicate, guess what? It's going to look like you have dementia, and it's really hard to do anything about it because that part of the brain is hurt. Last couple slides. And sorry, we're running over just a minute or two. The Lancet Commission shows, and most recently this year, they released 40% potentially modifiable dementias. So these are the risk factors, and as you get older. So early in life, remember those adverse childhood experiences we're coming back to, trauma-informed care, less education and trauma, huge increase. If you guys remember, some of you might have done like 23andMe or you hear of ApoE protein, and there's a lot of talk about that. Just to put into perspective, ApoE protein, if you have both of those genes, it's still less than trauma and hearing loss and those things. So just to put in perspective, some people kind of put a little overemphasis on that. Midlife, I tell my patients they need to get that hearing aid. Even when the older guys refuse, which I often do, I say, just so you know, it's a higher chance of, and they, oh, okay, I'll get it. Traumatic brain injury, all those hypertension, alcohol, obesity. And then look at all this percentage increase. I mean, smoking, depression, isolation, physical activity. I mean, think about that. Out of the 5 to 7 million Americans with dementia, potentially 3 million are modifiable or preventable. That's staggering. I'm going to just skip ahead. This was a finger study that we talked about before, and I'm just getting into what can you do to help patients. And this will be something we share. But again, this gets into the whole team-based approach. We're using physical therapy, occupational therapy, social work, everybody. And then what I wanted to do is ask about audience examples. And these are resources I rely on heavily. And so these are like Alzheimer's Association and all the community resources. And then I'll send this out to you, but there are some sheets you can actually give to patients or family members for their visits with their doctor. So to think about what to ask the specialist or the primary care or the geriatrician, keeping track of medications. One big thing I do is take people off of medications. Don't underestimate how much medications can cause problems when you get older. So there's a whole long list of medications older people should try to avoid, including anticholinergics. So think of Benadryl, and anything related to Benadryl, we really try to avoid. I apologize for rushing at the end there. There's quite a bit, but I'm always happy to stay late, answer questions, and also during future talks, please ask questions. Should we spend any time doing anything now? Or I know if you guys have to, if anyone has to go, I know the hour is up, but I'm going to hang out and answer any questions if you have any.
Thank you. Yep. So there is also an evaluation link in the chat box. So if you can take a minute and fill that out, that helps us. And if you do want to ask any questions, you want to hang around, just unmute yourself.
Awesome. Thank you, guys. And remember, we'll be back in 2 weeks for the next talk.
I don't see any in the chat box.
Yeah, I'll hang out for a bit just in case
Okay.
anyone's being shy.
I do appreciate that you brought up, with, especially from what I'm seeing, like even in epigenetics for trauma, that's a whole methodology, or not any methodology, but just a concept, I guess, just very confusing, but very interesting to see how trauma affects our brain.
Yeah.
And reactions, how we react.
And I suspect we're going to, oh, go ahead. Someone asking something? I thought someone said something. Yeah, we're going to get better and better at identifying those effects of trauma and being able to quantify that. And then in older life, being able to see people in their living situation and actually help them address those and modify those risk factors. So just because you had a trauma when you were a kid doesn't have to guarantee that it's going to increase that dementia risk. We can actually treat you in midlife or late life and try to help that. That's why I spend so much time, and luckily in my work, I can spend more time with patients, but I spend so much time being very specific about the diagnosis and trying to tease apart what's contributing to which symptom. And that's extremely important. One thing I was going to also throw out, Alona, was that as early as March of 2021, we may see FDA approve the first disease-modifying treatment for Alzheimer's. And there's quite a few in the pipeline. So I think in the next year to two, we're going to be seeing new drugs for the first time in a long time for Alzheimer's and other dementias. So it's going to be, we're really at a crossroads. I say to people, if you look historically, like where cardiology was in the 50s and 60s, where cancer was in the 80s and 90s, I think dementia is reaching a point where it's at least, there's going to be a point where we're going to have new therapies available.
That's great.
Mike just asked, what defines a childhood trauma? Eric, do you want to take that actually? Because Eric is our resident expert.
Sure. So there are lots of ways to define childhood trauma. The most, at least for now, the most widely accepted is sort of based on the ACEs study, ACEs standing for Adverse Childhood Experiences. And trauma, right, if you ask an emergency room doc, trauma means one thing, which tends to be sort of physical trauma, like breaking a leg or an accident, traumatic brain injury. When we're talking about childhood trauma, we're talking about sort of chronic toxic stress that's caused either by physical variables or actually emotional behavioral. So for example, in the study, there are 10 ACEs, 10 different ACEs that were defined. One category is household dysfunction, which includes parental separation, a family member who was incarcerated, family member with substance use disorders, mom being a victim of domestic violence, and gosh, I think I'm missing hang on, there's mental illness, separation, domestic violence, substance use, incarceration. All right, some family member incarcerated. And then there are 3 forms of abuse, physical, emotional, and sexual abuse, and then 2 forms of neglect, physical and emotional neglect. So those are the most sort of widely accepted categories of trauma, but they're, for example, one that's not described in those 10 is homelessness, right? So a child growing up in a homeless situation, that's also potentially traumatic toxic stress. So anyway, so I hope that's helpful.
Thank you. Yeah, that's very clear. Any other questions? And feel free to type them into the chat or just unmute yourself. But one thing I've noticed too with taking care of patients with dementia is as the dementia sort of severity increases and as it's diagnosed, I've noticed their childhoods absolutely inform the kind of issues they have with their memory. So for example, I saw a patient on Monday she's amazing. She's 93. She has Alzheimer's disease. She's Japanese. So she was in one of the Japanese internment camps. And she's very perceptive about that. Every visit she talks to me about her Japanese internment camp experience. And so she's kind of forthcoming about the trauma and she was a child then, but that's in the world of her dementia, that's what keeps coming up over and over again. And so it's how to be respectfully supportive of that. And that really just takes center stage with every visit. Oh, and great. Mike is also asking, how are we supposed to assess for trauma upon admission to a long-term care facility, I think is the question. And I know, so Eric spoke to this to some degree in the first, and you can access those slides online as well, only because we can talk about it now, of course, but there are some tools we referenced. So there are some like surveys. You can actually start by just giving out a simple survey. Did you have, and then some of them are just as simple as a few questions like, did you have a childhood experience? Did you fit into one of these checkboxes? And that can kind of help you screen and identify. And that's really all that's necessary in a sense. And then you can follow up and ask, hey, do you want to talk about it? Or how do you think it affects you now? You don't have to go through the details. Eric, do you have any specific examples?
Yeah, I think to your point, I think it's less important, right? Because the thing is, you don't want to ask questions about which you can do nothing, right? In other words, so let's say they say, yeah, no, I've had 7 adverse childhood experiences. That's sort of helpful and not helpful, right? So it's helpful to know that they've had a pretty they've had a very challenging sort of upbringing. But what I guess what I would suggest or think about is if you're going to ask these questions, be prepared. You be prepared, or your team be prepared to how to kind of respond to these things. So, and again, immediately you don't need to respond necessarily to anything. I think what's best to I guess what I often think about when I'm working with patients is instead of kind of thinking, gee, what's wrong with you? I think about what's happened to you, right? And so that's a frame. It's a different frame to interact with a patient. So I assume when I'm working with patients, I always assume there's sort of a backstory, a traumatic backstory somewhere in there, because like the prevalence of adverse childhood experiences is 2/3 of the population has experienced at least one adverse childhood experience, and one in 8 have experienced 4 or more. So so I guess what I would do is instead of kind of going right into it and saying, hey, tell me about your average childhood experiences, I would start first by forming a relationship, then assuming that there are potential triggers that somebody might have because of potential adverse childhood experiences. And as you get to know them, and if you start observing some things, then you can kind of start bringing that up. I don't know that it's needed right off the bat, but being sensitive to this.
That's a good point.
Yeah,
that might be something in terms of quality wise, you build into your 1 month follow-up, or do something where it's more standardized later, because you're absolutely right. There's no rush. You don't have to do this right away. And to Rebecca's point here in the chat, sometimes you have to ask family members, because if somebody has dementia, it might be impossible, very difficult to get that information. So absolutely, having the family members involved and caregivers to really understand is critical.
And sorry, so one other point, sorry. One of the biggest problems, or one of the biggest consequences of being exposed to trauma, or let me put it this way, one of the biggest problems related to trauma is lack of control, right? So being physically abused, sexually abused, being put in situations that are uncomfortable or damaging, is a person not having a sense of control. So one of the issues I think that can be brought up in long-term care facilities is what can one do to give people a sense of control as much as possible, giving choices, giving freedoms, doing that, because otherwise it can be triggering, right? So if on how you communicate about, let's say, I don't know, meal times or schedule and that sort of thing, the way that's communicated is important, because there's a history of trauma, and having lack of control that can trigger certain reactions. So anyway, so I think the more I mean, structure is great, but I think making people feel like they're empowered and have a sense of control is critical.
Mhm. And Alona, this is actually a really good point. You just brought up like an example where if you have a female patient or resident and they were sexually abused by a male earlier in life, you're careful not to give that person a male caregiver for like baths or intimate times. Now, to that point, if that patient has or a resident has dementia and can't even bring that up, you may not know about that. And so maybe, let's say we accidentally give them a male caregiver, they're helping them get ready for their bath, and that patient gets agitated, is like fighting. And we think, oh, let's give them some Risperidone, let's give them an antipsychotic. That's kind of the whole idea, is that if we can address this, you won't need to use a medication, because it turns out to be, oh, they're just feeling very uncomfortable, but they're not in a position to be able to say that. And so that's a very good example of where I've seen multiple times the ability to actually avoid medication and avoid injury by doing this.
And maybe Alona, to Alona's point, I wonder then in a situation like that, Reza, maybe it's almost more important. It's less important to ask about ACEs, but more important to ask family members, hey, what are certain situations we should avoid? What are certain situations that cause agitation? And over time, you'll figure out if it's related to ACEs or not. But again, you're trying to identify triggers and avoid those.
Yes. Great questions, great contributions. And you guys anyone can reach out outside of this too. I'm very happy to speak to this outside of these hours. And
Well,
Alana,
was it definitely?
Oh, go
What's
ahead.
that?
I'm
I was just going to say.
I'm going to send you the slides too, so you can post them as well.
Perfect. Okay.
Yeah, and Mike, I would say this is a task for anyone working directly with the patient on a regular basis. And I think depending on where you work at the facility, you can sort of organize that and say, we do have social workers, so we'll have them take that on, versus just depends on where you work and what's available.
And then to that point, beyond long-term care facilities, we've done some work with hospitals and critical access hospitals and outpatient settings. And it really helps to inform your policy procedures and your orientation process. So you change that organizational culture. A while back, I can't remember when it was, we had Jennifer Busher from the Children's Chaudhary Hospital, and she talked about the sanctuary model and how Chaudhary has used this model to change their trauma-informed organizational culture. And I think once you learn more about it and you put some meaning behind why you need to assess for trauma, not only just at an individual level, but also so you're not re-traumatizing both your staff and your residents or your patients in your facilities.
Absolutely. Wonderful. Great.